Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And, I always tell you there's a lot of interest in a lot of things that we do, but, one of the top three are issues relative to cardiovascular disease, heart problems, heart attacks, but always people want to know about these new interventional cardiologic issues, the minimally invasive issues, because cardiology has changed so dramatically over the last decade, or really the last 4 or 5 years almost. So I brought in two experts. What's better than to having experts? In front of me is Dr. Maini. He's an interventional cardiologist at Palmetto General Hospital here in South Florida. And welcome, Dr. Maini.
Thank you for having us.
Thank you for being here. And Michael, otherwise known as Mike, or is it Miguel?
Miguel, but call me Mike.
Okay, I'll call you whatever you want.
Thanks, Fred.
Dr. Diaz, who is also an interventional cardiologist. So thank you both for being here. Let's talk about, like I said, we get a lot of inquiries from our viewers about cardiac, what they believe is surgery, which is in many cases. But they want to know, why is it so different today? Talk about it, Mike.
Well, it's becoming different because there has been a pretty steady progress from more invasive to less invasive. So the idea of traditional heart surgery, where people required a large chest incision with the associated pain and recovery time, as through technology we've been minimizing the incisions, and eventually we are now getting to the point where we can do a lot with catheter-based procedures. So it's been a pretty steady progression from more invasive to less invasive, and I think that's what a lot of the callers and a lot of the people who watch the show are probably getting at is how has that transition occurred, and what's the future moving forward?
Well, there's no question, because, one of the things that we hear from our viewers all the time is because surgery in their minds means a lot of cutting, a lot of blood, and a lot of pain. But in particular in your field and in a lot of areas, I mean, orthopedics, cardiology, minimally invasive techniques have now bridged that gap. And now, my intent of bringing you here both today is to let those folks know that even though we still have open heart surgical procedures and things of that nature, but the interventional cardiologists are changing the view of not only the people who watch the show, but of the health professionals, your own colleagues. So, Dr. Maini, let's talk about it.
So I completely agree with Mike as to what he said. But the other side of the story is that the baby boomers have come of age. The population has grown. They have lived a better life through medicine. They did not pass on because of infectious disease processes and so on and so forth. Now they are in their 80s and 90s. And now they have valvular heart disease, other cardiac issues that we were not treating 30, 40 years ago, because the incidence was not as high, number one. And number two, we did not have the technology. So now we have the patients, and at the same time, we have new technology which we can offer these people. And even more importantly, I think we've done plenty of research to support that these technologies are not only as good as open heart surgery, and in many new areas, they're actually superior to the traditional open heart surgeries. So it's a combination of a lot of things. The population aging, technology getting better, our results from research trials suggesting that we're indeed going down the right path, which I think is the key to success. And obviously, if you have an 80-year-old person or a 90-year-old person, what would they want? A small puncture in the groin versus a big fillet of the chest? Certainly a small puncture in the groin is the way to go.
So that's what you're talking about. But in essence, the product, otherwise known as the person, and I don't mean to demean their human status, that is presented to you is often in better shape than they were 20 and 30 years ago. Is that true, Mike?
Absolutely. I mean, this is born out of necessity. I mean, the 70, 80, 85-year-old who is now here in Florida, like you say, they are much more active than even the 65-year-old was 30 years ago. So these are people who are living into their 70s, 80s, and 90s, but remain active and remain functional and remain ambitious as to what they want to do on a daily basis. And so through that was born this advent of technology and this desire to try to get these patients to be able to have procedures that were for many years felt to be prohibitive at their age. And how do you get this person who wants to remain as functional and active as they are, but they are advanced in age, how do you get them to a point where they can remain active without necessarily going through the rigors of a very invasive or high-risk procedure? And so that, I think, was one of the big impetus for developing a lot of these technologies that we're going to talk about today.
Well, let's start talking about some of these technologies. So go right ahead, Dr. Maini. Let's let the people out there know. Because,
Awesome.
you know, again, Mike was just saying, Dr. Diaz. I'm sorry, I'll call you Dr. Diaz. Was saying that, you know, most of the viewers, when they talk to us through mail or email or whatever, or phone call, they're just looking for an opportunity to have the quality of life that they hope they would be able to live after retirement, or working hard, or bringing up families and whatever. And they deserve that opportunity. So let's talk about some of the new techniques.
Right. So before we talk about new techniques, I think there's been a change in paradigm in which physicians are not practicing cardiovascular medicine. This is no longer an individual sport. It is a team sport. Hence, me and Mike work very closely with each other. We are standing next to each other in our cath labs and hybrid operating rooms. We are looking at these patients together. We are discussing this. This never used to get done in the years gone by. I would do my thing, Mike would do his own thing, the other doctor would do their thing. But now we discuss these cases, we operate together, we follow these patients together. The idea is truly to provide patients the finest care that anybody else can provide. And I think, you know, don't you agree with that, Mike, that this is truly becoming a team sport, which I think is very important when we start talking about these new era procedures. These new era procedures would not be successful if it was not for this team effort approach that not only us, other people around the country are using the same format, are utilizing.
Yeah, I agree 100%. I mean, the complexity of the patients because of advanced age is getting higher, and the complexity of the techniques are getting higher, and the only way to kind of tackle both of those simultaneously is you know, the team approach that Bridge mentioned, the multidisciplinary, where you have multiple specialties putting in their 2 cents, and that's how we're getting good results. When everyone gets an opportunity to chime in and to give their opinion, and then we go a step further, and like you said, we actually are together in the room together, in the suite together, doing these procedures. 4 eyes is better than 2, and 6 is better than 2. So as a result of that, we're getting the good results we are.
And also, I brought this to the attention of our viewers, a few shows back, when I mentioned the hybrid ORs, the new hybrid ORs. You want to just give us a touch of, let the people understand what the difference is? Go ahead, Mike.
So it's as the word implies, it's a kind of a marriage between what used to be the angiography suite, where we did cardiac catheterization procedures, and the operating room where they would do open heart surgeries. And so it has the equipment necessary, so the combination of X-ray equipment and hemodynamic monitoring, so blood pressure and heart rate and all that can be looked at like we have in the cath lab. But it's got the physical requirements, such as the way that the air circulates in order to prevent infection, and the size necessary to have all of the surgical equipment, including the heart-lung machine when it's necessary, all that, in order to be able to do procedures that can sometimes toggle between the interventional cardiology world and the cardiac surgery world, and they can seamlessly go between one and the other. based on what's right for that particular patient.
Who would have thought about replacing a valve, an aortic valve, years ago, the manner in which you're doing it?
Right.
So let's talk a bit about that.
So let's talk about valvular heart disease in its entirety. So
Go ahead.
the commonest valvular heart disease in the United States is actually mitral regurgitation. Leads to a lot of morbidity, mortality. Is one of the commonest reasons for hospital readmissions. And as of right now, till a few years ago, the only treatment options were open heart surgery, either mitral valve replacement or repair. And even in the best of circumstances, these people would not do well because they were old. They may be a good 85-year-old, but you're still 85-year-old, subjected to an open heart operation, heart-lung machine, rehab. You almost never come out of it, so to speak, right? So fast forward and say, how about if I can replicate the same process by putting in a clip and decreasing the leakage from 4 plus to 2 plus to 1 to 2 plus. Sometimes we get lucky to trace. That in effect is going to have the same result as somebody would have if you were to do open heart surgery. So when we started doing this technology about 12, 13 years ago as research, everybody thought this was not going to work. How can you put a clip on the mitral valve and have a change in outcomes and quality of life? And unbeknownst to us, many years later, we now know that these patients do a lot better. And in the Everest trial, people did phenomenally better with just a clip. So now there's obviously more research that's going on. So this clip is now approved in the United States for degenerative mitral regurgitation in patients who we think are high risk and sometimes prohibitively high risk for open heart surgery. So we are offering this technology at Palmetto. Me and Mike are working very hard to provide this to the local population in and around Palmetto General Hospital. So that, I think, is a game changer. It really improves the quality of life. We've had multiple patients that could not breathe, could not take 1 step, 2 steps, bad heart failure, multiple hospital admissions for congestive heart failure, are at home, doing great, fantastic quality of life. Now, the one thing that we all have to understand is that these devices have not been around for that long that we can comment whether there is a mortality benefit at this point in time. We are part of studies which are looking at, is there actually a mortality benefit? So we cannot take credit for that at this point in time. All we can say is improvement in quality of life, because that's as far as the data goes right now.
Dr. Diaz, let me ask you this question with reference to the issues of valvular the actual transplant of valves. I know that that's an issue that's come to South Florida. I mean, and certainly it's all over the nation.
Sure.
Are we involved with any of that at this point in time at Palmetto General?
So, along the lines of what Bridge was saying, the first step has been along the lines of repairing the valve and being able to repair the valve just with a skin puncture, which is the mitral valve clip. And what we've seen is a lot of improvement in how patients feel, less hospital admissions. So daily quality of life, which is what so many older patients really want, has been achieved. But that's a springboard. Like everything else, the technology continues to evolve. And so pretty soon we will be involved in actually being able to replace the mitral valve completely through a non-surgical approach. Right. And so Bridge has done a lot of work on that already, and he's got some research and some trials that we're going to be bringing in hopefully shortly.
So we have access to those trials. There's 5 sites around the country that have access to early feasibility mitral replacement trials. So the way this is done is obviously without a heart-lung machine. So small incision is made through the ribs in the left intramammary area, and you go through the apex of the left ventricle, and you can implant a new valve in the mitral position. So about 50-some have been done around the world so far. As I said, we are very proud to say that we have it within the Tenet, Florida region. And our patients do have access to it. So And so that's the first line. There's a couple of other devices that are becoming available to us in the next couple of months as well for replacement. Now, these are being studied both for degenerative as well as functional mitral regurgitation, which is a huge chunk of the patient population who have dilated cardiomyopathies, ejection fractions, which are poor. These are the patients who have recurrent heart failure admissions. So the idea would be is to see if replacing these valves in these very sick hearts, how do these people do? So again, this is research in progress. The early feasibility data is very promising. But again, we don't have long-term data. It's going to take years by the time I think this becomes standard of care. The good thing that I think is happening is that the FDA has had a change of heart. And as you may have realized, all these new technologies would be done initially in South America or in Europe, and then eventually, many years later, would come back to the United States. So now the FDA says that they're going to allow us in the United States to do early feasibility studies. And as I said, both me and Mike are very happy and proud that we are part of those early feasibility studies.
Well, it is. That's you should be proud. Just a question. We had a question from one of our viewers about aortic valve replacement.
Yes.
Let's talk about that.
So along the same lines, aortic valve replacement and the idea, believe it or not, the idea of the minimal mitral valve repair kind of probably started around the same time, but because the mitral valve is a much more complex structure, it's taking a little bit longer. But the idea of replacing the aortic valve with a skin puncture technique, a catheter-based technique, has been fairly well established now for a few years, and we're participating. The entire Tenet region here is, and it's called TAVR, transcatheter aortic valve replacement. I think Bridge has one later this afternoon, and so do I. So that's something that's developed, and it's kind of very encouraging to see how that has developed, and if we can extrapolate that to mitral valve disease would be excellent, because at this point, for patients who are high risk for surgery or cannot have surgery, TAVR is the way to go to replace the aortic valve, and we're fairly confident now that even patients who are intermediate risk, but who may be older in age and maybe the heart-lung machine is not a good idea for them, it's as good and possibly better than conventional surgery as well. So I think TAVR is something that's very well developed at this point. No longer, I think, should be considered experimental. It's certainly something that primary care doctors and cardiologists should be considering very strongly for their patients who are up in age and have severe symptomatic aortic stenosis.
Let me to get to the commonality or the talk that we have around the breakfast tables or dinner tables. Explain the difference between a mitral valve and the aortic valve to these folks out here.
Okay, so the heart, there's the right side of the heart and the left side of the heart. On the left side of the heart, there's two major valves. So the mitral valve, which is a much more complex structure, it regulates the flow of blood between the atrium and the ventricle, the atrium being the top part of the heart, the ventricle being the bottom part of the heart. So flow of blood within the heart itself. And so when the mitral valve leaks, doesn't close properly, you can get backflow of blood. So as the heart contracts, blood should go out into the body in order to supply the brain and the tissues of the body. But if it leaks backward, it can end up in the lungs. And when blood and fluid end up in the lungs, you have shortness of breath, pulmonary congestion, and heart failure. And so that's the mitral valve. The aortic valve is the kind of the regulator, the valve that regulates how blood flows out of the heart into the body. And so it's supposed to open when the heart contracts, and it's supposed to close when the heart is filling. And if it won't open when the heart contracts, which is what happens with aortic stenosis, it develops calcium and the leaflets become very restricted and they can't open, then patients start to fail in all fronts from a standpoint of heart congestion, trouble breathing, chest discomfort, which we call angina. And so there are two separate valves that work very differently, but similarly dangerous to patients as far as when they go bad, how severe the symptoms could be and how significant the mortality could be.
So, Dr. Maini, as a veteran in the field,
Sure.
You must be very excited about
Yes.
all these changes.
Indeed. So, as a classically trained cardiologist, to be truly honest, I never dreamt in my wildest dreams that we would be replacing valves, repairing valves. This is very new for us as well. When I say new, means we've been doing research in this field for many years, but the outcomes and the results that we are getting are spectacular. So along those lines, I want to shift gears and talk a little bit about the tricuspid valve, a little bit about the right side of the heart. And there's a lot of morbidity that happens because of that. Lower extremity swelling, abdominal bloating, loss of appetite. A lot of elderly patients have that. Unfortunately, the only treatment that we have is give them Lasix diuretics. And there's traditionally not been any treatment because you don't want to send an 85, 90-year-old to the operating room for an isolated tricuspid valve repair. That carries a very high mortality. So now what we can do is go in from the neck and put in a suture in the tricuspid valve with just catheter-based technology. So this is a device called the Triline that we are trialing. And this trial is available to 5 to 6 sites around the country at this point in time. So the idea would be is if I can offer this treatment in a kind of an awake patient and put a suture in through the neck and decrease the leakage in the tricuspid valve on the right side, now just imagine the improvement in quality of life that may happen. Again, very early research, but in the next 5 years, 10 years down the line, these technologies, if all goes well, are going to hopefully be standard of care. Less medications, better quality of life, no swollen legs, better appetite, and you're 95 years old and you're running around. I think that would be fantastic.
Oh, I think the viewers and their moms and dads and grandparents would be very, very happy.
Yes.
But that's why we bring people like yourselves onto this show, because we're really an information and answer show. We get a lot of questions from the viewers, a lot of questions. And I really appreciate your description and your knowledge, because these are the types of things that they want to know about. I mean, again, and then we're going to get to another area. It's a little bit primal relative to what you do, but they're very interested in the quality of life, very interested in quality of life. Nobody wants to work their whole lives,
Yes.
and retire and then find themselves in a situation where, oh my God, I should have retired 20 years ago if I would have known this. But they can't, because, the cost of living out your life is dramatic, So the quality of life is such an important part of this living out their lives that we're very pleased to hear what you have to say. Let me ask you, just both as cardiologists, as physicians, relative to the patient. We always try to give them hints relative to how to keep heart safe, how to deal with these things. Certainly I'd like to talk about, how many times should they visit their physicians when they're 40 to 50 years old, because that's that state of omnipresence. Nothing happens to me between 40 and 55 or whatever. But so let's just talk a bit about that, a little common talk about what these folks ought to be aware of so that they can tell themselves and tell their sons and daughters, instead of just sitting around, what should they be doing?
Well, I think education is key. So staying informed of things that they should be looking out for, especially between that ages of 40 and 50. I think a yearly visit to their doctor is an excellent first step. It's then incumbent upon us, I think, to stay in communication with primary care doctors and make sure that they're up to speed with all of the new technologies. But as far as just general cardiovascular health, risk factor modification, so getting away a little bit from structural heart disease and looking at still the number one killer in the Western Hemisphere is cardiovascular disease, coronary atherosclerosis. So So risk factor modification. So getting a hold. I think the AHA has their campaign, knowing your numbers, right? So getting a hold of your blood pressure value and your cholesterol value and your blood sugar value, and starting there. But tailoring away from that and toward the issues that we've been talking about today, as far as structural heart disease, if there's going to be abnormalities that develop of the mitral valve or of the aortic valve, patients need to be aware of symptoms. So trouble breathing during activities that previously you did not have difficulty doing, chest pains, passing out, arrhythmias, abnormal heart rhythms that may develop. These are all things that should be red flags for patients and for primary care physicians to look a little bit more deeply into the possibility of valvular heart disease.
Dr. Maini?
No, I agree, but I think I would take a step back and say, you know what, we don't want to start when you're 40, 50, 60 years old. We want to start when you're much younger. Childhood obesity is a big epidemic here. The concern is when these kids, when these teenagers come of age, these patients are going to have diabetes, bad coronary disease. It's going to be a nightmare to deal with. So I think we need to focus a lot of energy at these very young people who technically on the face value are doing just fine. They drink a gallon of Coke every day. They probably smoke. They're not taking care of themselves. They're not exercising, which is not good. A lot of pre-diabetics. And that, I think, in my mind, is a precursor to what we will eventually, or may not be me and Mike by that time, but it will be somebody in the cardiovascular field who will be taking care of those people, which will not be good if we do not tackle them right now.
Yeah, all right. Well, we're down to the last minute and a half of this show. I'm very pleased that we got to talk about these new procedures, but I always tell the folks at the end of the show, take good care of yourself.
Yes.
And Dr. Diaz, you certainly have said it. I mean, people should have regular visits to their doctors, a minimum of once a year, because that minimum. And clearly, exercise, nutrition, hydration are elements of preventing diseases. I'm looking at two physicians that really believe that the less patients, in essence, that you have to care for in certain conditions would be a blessing to both of you. I think I have that feeling.
Indeed.
Yeah, we feel that way strongly.
Right,
Sure.
right.
Good health is a gift.
Right, it's a blessing. So, Dr. Miguel Diaz, otherwise known as Dr. Diaz, and Brijeshwar, both interventional cardiologists at Palmetto General. Thank you very much for a very informative show. If you have any questions, you have any comments, just let them come forward. Remember, as I always tell you, and you just heard it from Dr. Diaz and Dr. Maini, you got to take good care of yourself. And that means don't hold things back. Tell your doctors. You have to tell them. Yes. You know, when they ask you what you think is a silly question about what you're taking over the counter and what kind of nutritional products you're taking, et cetera, it affects their knowledge if you don't give them the information. So please take good care of yourself. Remember, this show is your show. It's called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see ya.